been treating osteoarthritis or say arthritis since last 20 years. And we see both types of arthritis. One is osteoarthritis and other is rheumatoid arthritis. There are other forms of arthritis also, like psoriatic arthritis and many other connective tissue disorders which lead to arthritis, but they are not that common. The commonest is osteoarthritis, which is very prevalent in Indian women, especially postmenopausal period and those who live sedentary lifestyle. For them, in them, it is more common. When we talk of population which is dwelling in the town area, they are more aware of these kinds of issues, as well as they have access to healthcare systems, so they come quite early. But when we see the patients who are residing in village areas, they generally tend to come in later stages. So in town, we can see patients coming in stage 1 and 2 only, whereas in villages, we see that they come in stage 3 and 4.
But
And many a times they have learned to live with the stages as they progress, and they're not aware. And suddenly, when we see the X-ray, it shows that it's in stage 4.
okay.
So it depends upon the stage in which the patient has presented. So we identify the stage, and accordingly we decide the treatment for the patient. It may include medication in form of NSAIDs, which are given on a SOS basis, and we give cartilage protectors and medicines which help in regeneration of cartilage. And we also give chondroprotective hyaluronic acid injections for the knee. And there are other forms of injections also, like say PRP, which is platelet-rich plasma. So we give those injections also, especially in these things we do in stage 1 and 2. And as the stage advances, we need to go in for some surgical procedures for them. Non-surgical treatments include physiotherapy, that includes different sorts of heat modalities which are given, which includes interferential therapy, ultrasonic therapy, shortwave diathermy. So these are the different types of physiotherapy, and it also includes some exercises for the patients, which is like to strengthen the quadriceps. So that's called quadriceps drill, and cycling exercises. So non-weight bearing exercises which do the movements of the knee, those are done. And we tell them to decrease their weight, so that as the weight comes down, the weight borne by the knees also comes down, and so does the pain of the knee. So decreasing the weight also, because most of the times the people who present with us have got more BMI, so we tell them to bring it down. And that's what, like, say, they need to take proper diet for that and do some exercises for that. See, exercises can be just focused on the knee, as well as in general exercises. And we also tell them to walk, because walking is not something which damages the knee. It's chondroprotective, because it is done, the weight bearing is under control. So we recommend them to walk within limits of pain. So those are things we recommend to the patients, non-invasive, non-medicinal.
Okay.
Yeah. And as you have also highlighted, some inclusion in any sort of sort of physical activity which does not involve a lot of stress and strain over the body, that can also be done. So we give the patients the medication, physiotherapy, and tell them to alter their lifestyle. And we see the results because we call such patients for a follow-up after a few weeks and all. And we keep on seeing whether they're responding well to the treatment or not. If they're not responding to all these treatments, then only we go in for some other measures.
So
all the three would be fine to decide on that. The surgical procedures, it depends upon the X-ray finding. We generally do a weight-bearing X-ray for the patient, wherein the patient is in a standing position. So that gives us a real picture of how much of the cartilage is degenerated. We also do a scanogram. Scanogram is something which is done from the hip, knee, and ankle. It involves the three joints in the standing position. We also look at the biomechanical axis. The biomechanical axis is a line which is drawn from the center of the hip joint to the center of the ankle joint, a straight line, which ideally in a normal human being should be going through the center of the knee. And that decides as to whether the knee is in a varus or a valgus. So depending upon that, and we decide and we plan to bring the biomechanical axis to a neutral position, like how it was naturally meant to be. And the surgical procedures for that can include, to start with, see, the end of it is the total knee replacement. But we try to avoid knee replacement in the earlier stages. And we go in for doing some osteotomies. In those osteotomies, like say we do a medial opening wedge osteotomy, where on the inner side, if it is, most of the times what we come across is a varus knee. Varus means the knees go away from the center of the body. So that's a varus knee or a C-shaped knee. So it depends on what kind of knee is the presentation, whether it is the medial compartment or the inner compartment. When the inner compartment of knee is involved, it leads to genu varum. And when the outer compartment of knee is involved, the knees touch each other, and that's called as knock knees. And the feet are away. So depending upon which compartment is involved, we go in for osteotomies. So for a medial or compartment involvement, we'll go for a medial open wedge osteotomy or a lateral closing wedge osteotomy. And it'll be just the opposite in a case of valgus knee or a genu valgum or knock knee. So that is one of the procedures, that is osteotomy. And then the other surgical options are, before that, if we want, sometimes we can just put an arthroscope into the knee, and we can remove the osteophytes. Osteophytes are extra pieces of bone which are grown there, and the synovial hypertrophy, if it is there. So that all these things can be removed by doing a scopy, arthroscopy. So, and then the other option is a knee replacement to change the knee. So that can be a unicompartmental knee replacement, wherein the compartment which is worn off, only that is replaced. Like say if the medial compartment is worn off, that is replaced. Otherwise, we can go in for a total knee replacement, wherein we replace the distal end of femur and the proximal end of tibia and replace it with a prosthesis. These are the different surgical options.
Okay.
Okay. So one of the important things is that we look into the failure of conservative treatment in such patients, and we also look as to how much their activities of daily living, ADLs, are getting affected by the degeneration of the knee. And so once the ADLs are affected and the patient is not responding to the conservative treatment, so on that, we have to convince the patients. But the patients are different types. Many
Right.
of them will be convinced earlier. Many of them would like not get convinced despite how much soever we try. So we ultimately leave the decision onto the patient because the patient has to give the consent for any procedure before we take up the procedure.
Um,
Lifestyle changes and early interventions, like obviously lifestyle changes, all those things, they help in if the patient has presented earlier. So um, we tell them to have an active lifestyle involving some sort form or some exercises daily, which involves exercise to do with the knee and general body, and say something like say walking, yoga, and so and dietary habits also they have to change, and like say what time what food should be taken so that the weight does not increase, and if at all their BMIs are high, then how to come down to a lesser BMI. All sorts of things are told to the patients so that they can live, or like whatever osteoarthritis stage they are into should not be progressing.
okay.
Um, we have to try to convince the patients, and there are many patients who live their life with stage 4 and with a lot of deformity, and they're not willing, even if like they're in India, we have got two different types of scenarios. One is a person who has a bad knee and is willing for a surgery, but because of some financial constraints cannot be moving further. And another is set of persons is who are financially fine, but they're not willing for it because of their own reservations. Like say, every surgery has got some other complications, and if they hear about some other person had got known person relative had got a replacement done and it was not very successful, or so they will have won't be willing for it. And one of the main concerns in India is that the first thing they ask is whether we can squat or not after surgery, whether we can sit cross-legged or not in after this surgery, which we don't allow them. But they're more bothered because most of our Indian traditions and customs require the person to be sitting down on the ground, either in squatting or sitting cross-legged position. So those are their concerns, but we convince them, and as well as other things to use the Indian toilet. I mean, Indian toilet, even any knee patient, is very difficult for the patient to use an Indian toilet. And as the age advance, as this grades advance, we tell them to go in for Western one, so that the pressure on the knees come down as much as possible.
Mm-hmm.
Yeah, convincing is an issue, but depends upon the set of patients whom we are interacting with. And some people are okay with leading their life like how they are. And so we can't do anything about that. We just have to put in our points
Mm-hmm.
and try to convince the patient.
Right. So those are all of my questions. Thank you so much. Is there
Yeah.
anything else you'd like to add?
It's okay. Everything is fine. I have gone through your handbook. It looks promising for the patients who are suffering, and it's something like if you get this handbook ready, probably even orthopedic surgeons can give that handbook to the patient so that the patients can follow.
Mhm.